Hi everyone, this is here from ABCs of Anaesthesia, and today I'm going to be talking about liver disease in anaesthesia and all the things you need to consider when you're anaesthetising a patient with liver disease. So let's get started. And what I thought I'd do is I thought I'd go to the BJA Education series and just take one of their latest articles from the recent publication. So this is BJA Education 22-3, pages 111 to 117, and it's titled The Perioperative Management of Patients with Liver Disease. This is the paper by Gilbert, Kawai, Hogan, and Milan, and they're from King's College Hospital. Again, the BJA Education series, as I've mentioned on previous videos, it's just a fantastic repository of really great review articles. So I thought I'd just take this article and look at a few really interesting points. So some of the topics we're going to go through are liver disease definitions, all the extrahepatic manifestations of liver disease, what are the impacts of liver disease itself, for example, bleeding risk, how to think about preoperative risk assessment, which means there's going to be patient factors and surgical factors. Going to the patient assessment, how do you optimize specific things for your anesthesia to try and make it safer for your patient? And what do you actually do differently intraoperatively and postoperatively? So let's get started. Now, broadly speaking, the way I think about this is in those ACC/AHA guidelines on perioperative cardiovascular evaluation. Now, if anyone's seen one of my lectures, I'll put a link there. And it's really about having a good framework for when to either postpone or proceed with a patient. So if you remember that mnemonic, every anaesthetist loves morning coffee. I think about the framework, is this emergency elective surgery? Is there an active condition? Is it low-risk surgery? What are the mets of this patient? And then will testing change management, see for change, and what are you going to do about it? So let's think about this in that framework. If it's emergency surgery, you really have to do your best to optimize this patient as quick as you can to get them through. Imagine this patient has had a ruptured AAA and also has liver disease. You've got a couple of problems there. You do your best to try and sort out a few things that you could optimize, which we'll go through later. But then essentially this patient needs to be rushed to theatre because that operative problem is going to be the issue. So that's relatively straightforward, though intraoperatively and perioperatively that is difficult, but the decision is easier to make. Now let's think about if it's an elective operation. Think about a patient going for lap chole. Now let's think about the definition. So we've got acute liver failure, chronic liver failure, and acute on chronic liver failure. Now acute liver failure, by definition, is going to be really tricky and high risk. For acute liver failure, we talk about the Grady classification. The time from jaundice to encephalopathy being less than 7 days is hyperacute, 4 weeks is acute, or up to 12 weeks is subacute. Now, if it's an acute process like that, or if it's acute on chronic liver failure, by definition, that's an active problem. So if you have elective surgery with an active liver problem, you really want to refer to a liver specialist and try to do your best in an appropriate time frame to optimize before you go into an elective procedure. Because by nature, your patient isn't optimized, it's unstable, and so you're going to have a high perioperative risk. Now, if it's chronic liver failure, then you take it to the next level, which is to check the severity of this disease. By nature, the chronic should be stable, so we're checking the severity of that disease. Now, chronic liver failure is generally due to things like viral hepatitis, autoimmune processes, maybe alcoholic liver disease or fatty liver disease. And as this disease progresses, you get inflammation, destruction, and then subsequent problems in extrahepatic sites as well. You may have problems with coagulopathy, for example, as well as your cardiovascular, respiratory system, etc. Now, chronic liver disease can be divided into decompensated or compensated. If it's compensated, often these patients might be undiagnosed or maybe asymptomatic. So generally speaking, you can talk to the liver specialist or the medical team, and you'll know that they're generally going to be stable and in a low risk category. If they're decompensated and they've got problems like ascites and encephalopathy, then you're a bit more worried, and then you'll have to think about this in terms of this is an active process, let's try to optimize this patient and sort something out. Now, this article talks about acute on chronic liver failure as being a syndrome of rapid onset deterioration of hepatic and extrahepatic organ function on the background of this chronic liver disease. So this is a really high risk situation, severe systemic inflammation, extrahepatic organ failure, and a high 28-day mortality. So you're going to be much more worried about these patients having that acute and chronic picture. But if all I told you was you've got an elective operation and you've got either an acute problem, acute on chronic problem, or some kind of decompensation, then that's something you need to refer. And that's how I think of that framework. Now, with every single medical problem, you've got to think about how that affects the organ systems that affect anaesthetists the most. And so when I think about that, I'm really concerned about your airway, breathing, and circulation most of all, and then a few other things which we'll come to. So Let's think about that for the liver. For the liver, the cardiovascular system, as the liver function gets worse, becomes a high cardiac output, low systemic vascular resistance state. So that means that even though you've got a cardiac output that's pretty fast, you'll have a lower blood pressure and you may need more vasopressor, more noradrenaline running, more metaraminol to keep the blood pressure perfusing your vital organs. You might also get some cardiac decompensation or cardiomyopathy from the liver disease. So again, depending on the functional status of the patient, you would then need to investigate this further. Now there's a lot of respiratory effects as well, like mechanically, just because of having that ascites, pushing up the diaphragm, you may have problems with your FRC being lower, less oxygen reserve, worsening pulmonary vascular resistance, increasing work of breathing, increasing airways resistance, and all these other things. So just the mechanical problems of having that extra weight there will cause you mechanical problems with your respiration, ventilation, and oxygenation. You can also get this thing called hepatopulmonary syndrome. Again, that will be one of the causes of hypoxemia that you need to consider. And often in these patients, they talk about having the supine or the head down or Trendelenburg position being a better oxygenation state for these patients. That said, often you just want the surgery to be done in the most efficient way for the surgeons to perform the surgery. So if they need the patient supine, that's fine. If they need the patient's head up for a biliary procedure, often whatever allows the surgeon to progress better is probably best. And it's probably something you have a discussion about depending on how bad the hypoxemia is. And you've got to think about a lot of the gastrointestinal things as well. For example, esophageal varices due to portal hypertension, that can be a problem because if you get some sudden intraoperative blood loss or hypotension, that could be due to a ruptured variceal bleed. Also, you're not going to be wanting to put down a transesophageal echo lightly if they've got varices. You just don't want to cause that trauma. So even temperature probes that you don't want to insert too far just in case that traumatizes one of your esophageal varices. Also got to think about renal impairment. So renal impairment, really, your hepatorenal syndrome, the risk of acute renal failure has increased, and then all the drugs you're going to be using during the procedure as well, you're going to have to think about. Now your next system is the central nervous system. Again, a patient with encephalopathy and decreased conscious state after having general anesthetic may recover a lot slower from the anesthetic, as well as interactions with other medications like benzodiazepines may be a problem. And your endocrine system as well, and your metabolic system, so all of your electrolytes will probably be on the low side, hyponatremia, hypokalemia, and hypoglycemia. So you're going to have to monitor them with regular venous gas or arterial gases depending on how severe or how big the operation is. Finally, there's the hematological system. So generally speaking, patients with liver disease will have decreased protein production, decreased clotting factor of the procoagulant and the anticoagulant side. So even though their INR might be raised, you have this balance or this homeostasis of just impaired both pro-clotting factors and anti-clotting factors. Also, you might have decreased platelets, but again, that's compensated for by increased von Willebrand factor. And so you've got this state where sometimes these patients might have actually normal clotting, even though their numbers are deranged, but other times you may have a problem. And you've got to think about all the other reasons why. For example, maybe the bleeding is due to hypervolemia or increased portal hypertension, or just surgical trauma and friable vessels and mucosal bleeding. So even though their clotting numbers are not as great, they might actually be okay. So one of the things you can do is use one of those point of care tests like TEG or Rotem, and that way you can have a more point of care, more realistic picture of what clotting is occurring. So one of the other interesting things is that when you're measuring the INR in these patients, you might be tempted to try and correct coagulopathy. So with coagulopathy, again, liver disease can cause so much dysfunction of many things. Your clotting factors, it's a decrease in not only your procoagulant factors, but also your anti-clotting factors as well. So often there is a bit of a balance there, but you might have a decrease in platelet function and as well as a lack of fibrinogen. So again, something to think about and something to think about when optimizing. So now what we've talked about is we've considered a patient having elective surgery and they say they don't have an active problem, but they say they've got chronic liver disease. Now the next thing is this low risk surgery? So let's say there's no active problem, but it's really low risk surgery, just a lump or bump excision or maybe a cataract operation or maybe some kind of scope. Then generally speaking, according to the ACCHA guidelines and other evidence, it's probably safe to proceed with the surgery. But now let's think about the patient who has not a low risk operation. Maybe, for example, say they're having a lap chole or some kind of laparoscopic procedure or laparotomy or even some orthopedic procedure. Now what you've got to do is think about your perioperative risk assessment. So let's do a couple of things where we firstly think about how to assess perioperative risk, and there's a few scores that I use time and time again, which we can look at. And then we can look at how to optimize your extrahepatic problems to make the patient less risk. So we take a risk scoring system and then we take the extrahepatic manifestations and correct those as best as we can. So now our patient is as healthy as they can be, we do a risk assessment, and then we decide to proceed or postpone based on that. So there's two commonly used scoring systems for liver disease, and I'd say these are the two to learn. So the Child-Pugh scoring system and the MELD score. Now, the Child-Pugh scoring system and the MELD score both have their problems, like they only look at certain facets of it. So again, you really have to look at the patient in the full context. But it's a common way of communicating with your colleagues, so I think it's really useful for you to know, especially when you're doing exams or communicating with your supervisor or your other colleagues. Just being able to say those things, they understand the picture that you're talking about easily, so you can hopefully do the best for your patient. So the Child-Pugh scoring system takes into account 3 biochemical markers and 2 clinical markers. So it takes into account the bilirubin concentration, albumin, as well as the INR, and the clinical markers are the severity of the ascites and the severity of the encephalopathy. And so you get either a score of A, B, C, A being mild, B moderate, and C severe, and then this is used to correlate with perioperative morbidity and mortality. So again, very useful, but it has problems because the biochemical markers are numbers which you can absolutely be certain of what that number means, but the clinical markers, you may grade ascites differently based on just subjective opinion, and that's the same for encephalopathy as well. Now the MELD scoring system takes into account creatinine, bilirubin, INR, and you can add sodium for the UK-ELD scoring systems, and then you get a score of less than 10, 10 to 15, or greater than 15. And they kind of approximate the Child-Pugh scoring systems of A, B, and C. Now, as you can see, this only takes into account a few factors. It doesn't take into account all the other things about whether this is acute decompensation, the risk of the surgery, and just the general state, metabolic activity, cardiac status, respiratory status of the patient. It doesn't take into account any of that hepatorenal syndrome, hepatopulmonary syndrome, where there's cirrhosis, cardiomyopathy. So again, you really have to take the individual clinical circumstance and the patient's condition into consideration. So don't take the scoring system as the be-all and end-all. It does, however, make it really worthwhile when you're trying to risk stratify what goes on. Now, this article then goes into a really useful kind of framework. For example, it has a little flowchart which might help a lot of people making their decisions when it comes to deciding whether to go ahead with surgery or not. For example, you've got the liver disease patient, you calculate whether, first of all, if they've got an acute problem, in which case you most likely have to defer, if it's elective surgery, to optimize and sort out the patient. But then if it's a chronic problem, you can determine whether it's Child-Pugh A or MELD less than 10, Child-Pugh B or MELD 10 to 15, or Child-Pugh C or MELD greater than 15. Now, if it's in the A or the low risk category, you could consider proceeding with caution, also going through these, trying to optimize the extrahepatic manifestations that we're going to talk about. So Child-Pugh B or MELD 10 to 15, again, you can proceed with caution, but there's going to be a higher perioperative risk. And again, we can talk about optimization strategies in a second. Finally, Child-Pugh C, this is a much higher risk, or MELD greater than 15, much higher risk. So again, defer, cancel, look at how you can optimize and make sure this patient has seen a medical team prior to proceeding with elective surgery. So let's go back to our framework. You've got an elective procedure. The patient isn't having an active liver problem. It's just a chronic liver disease. It's not a low-risk surgery. And now you're trying to find the risk stratification. So you do a full history examination investigations. You take all those numbers to find the Child-Pugh score or your MELD score. So really that means taking your history, doing an examination, checking for jaundice and encephalopathy, ascites, looking at all the other manifestations, spider nevi, as well as the umbilical or portal vein problems as well. So you're looking at all of that. You're doing a whole panel of bloods, including your FBE, looking for anemia and thrombocytopenia. You're looking at your white cell count, looking for infections, and your CRP as well for infective or inflammatory processes. Your UECs, which is your urea, electrolytes, and creatinine, looking for renal impairment, looking for your potassium and sodium because they're often hypokalemic and hyponatremic, as well as hypoglycemic. So you want your blood sugar level as well, and you can get that pretty quickly with a venous gas to also look at the pH. Your liver function test, looking at your bilirubin and albumin, as well as all your gamma GTs and ASTs and aminotransferase as well. And finally, looking at coagulation, looking at your INR and APTT, as well as if you've got a point of care test like a thromboelastogram, TEG, or ROTEM to see what the functional status of the clotting profile is. If you're really worried about this patient's cardiac status, absolutely get a cardiopulmonary exercise test or some kind of echo or stress echo if you're worried about that. And then you can get more information to risk stratify. So let's talk about optimization now. So there's a few things, extra hepatic manifestations that you could potentially optimize. The things that easily come to mind are if there's fluid in the incorrect places. For example, if you have ascites or large volume ascites that can be tapped and drained, that could really ease pressure on the lungs. And again, improve oxygenation, improve the excursion of your diaphragm during respiration. Same with pleural effusions. You can drain those safely. Again, getting your medical team or your surgical team to sort that out before you proceed with your operation. Now, treating encephalopathy is really important. Just remember that mostly these patients will be managed by a really fantastic medical team, and they'll already be on oral lactulose and neomycin, which is an antibiotic, to decrease intestinal ammonia, and that decreases that load onto the brain, which maybe isn't being processed well by the decompensating or failing liver. So the things that you might also consider, if they're not on that, is to make sure that they're started on those medications. But also, what are the precipitants of encephalopathy? And I've got a pretty good mnemonic here, which is bad diet. So B is for bleed, A is for anemia, D is for dietary protein, so an excess of that, which can often be like an intragastric bleed, D for drugs, including alcohol, I for infection, E for electrolyte balance, and T for toxins. And so if you think of the patient's circumstance, if they've got any one of these things going on, you might be worried about postoperative or perioperative encephalopathy, and you might want to defer until that's sorted out. Now, as we mentioned, you've got a whole panel of investigations, so it may be really useful to make sure that those investigations are in the normal range. If the HB is low, you might consider transfusing if it gets to your transfusion trigger, or there's signs of poor perfusion or oxygen delivery. If your platelets are greater than 50, generally surgery can occur. But again, make sure those platelets are functional. You check your coags, and interestingly, the way you can treat or optimize your coags is not always possible in liver cirrhosis, and it's probably thought that an INR of less than 1.7 can't really be corrected by giving something like fresh frozen plasma. And again, these blood products have their own risks and benefits, so really important to balance that. You don't want to just transfuse everyone if you're going to get limited benefit from it. Again, you can do rotum and teg, check that the fibrinogens are at an adequate level, often greater than 1 gram per liter is probably adequate, and using cryoprecipitate or fibrinogen concentrate might be the better solution rather than giving FFP, which has all the risk of transfusion-related acute lung injury or TRALI. Again, check your electrolytes, replace as normal, and look at your echo to see how it's going to be functioning during your anesthetic. So again, just going through those extrahepatic manifestations, really easy to see how you can potentially optimize this patient so they're better for elective surgery. Now, this also works in emergency surgery. Think about a patient that's going to crash into the theatre. Being able to quickly drain ascites with the medical team before you induce anesthesia may be useful as well. So let's talk about intraoperative and then postoperative problems. So most of all, most of your patients aren't going to be that decompensated. Their liver failure is not going to be that severe, so you generally go ahead with an anesthetic in a careful fashion. But you might consider a lot of additions to this. For example, having 2 large bore IV access to make sure you can give volume and blood if there's a bleed. Having an art line because these patients can be unstable under anesthetic, especially if they've got a cardiac problem or if they're hypovolemic. If you're going to be running inotropes, putting a CV in electively after induction or before, again, useful for getting that vasopressor up because you've got a very low SVI in these liver failure patients. Now, blood loss is often just due to the fact that there are other things rather than coagulopathy, but ensuring your coagulation profile is adequate, that your surgeon is able to operate effectively, and that your other things to improve coagulation, such as temperature, calcium, and pH, are all managed well. These patients are always at risk of bacterial peritonitis and postoperative infection, so making sure they're up to date with your antibiotic prophylaxis, giving you 2 grams Kef plus or minus metronidazole 500 milligrams, again, vital. Now, the one thing that we will often think about is regional anesthesia. ESRA and ASRA, so the American Society of Regional Anesthesia, comes up with amazing guidelines talking about what your cutoffs are and what the safe limits for coagulopathy are with regional anesthesia. But generally, as a conservative figure, having your platelets functional and greater than 100,000 per millimeter cube is pretty reasonable, and having your INR less than 1.4 is reasonable for most regional anesthesia. Again, there's always exceptions for this, so always seek advice from your supervisor and consider each patient as well. Now, liver failure and extrahepatic renal failure can pose a lot of problems with the drugs you're going to choose. So generally speaking, as a golden rule, it's not necessarily that you can't use the drug, it's just the way you use it that's going to be most important for these patients. Most drugs are metabolized by the liver, but the liver does have a lot of reserve, and so the reason that you're going to have problems is decreased metabolism, not absence of metabolism, but but also the lack of protein in the blood, which means that you'll have a change in the volume of distribution. So you have to decrease the dosage and the timing intervals for a lot of medications. So let's go through most of the things. So hypnotics, generally speaking, midazolam might have a bit of a longer effect. So propofol is pretty safe as a standard induction agent. You'd probably just want to go, start low and go slow in these patients and be prepared for a drop in your SVR. Therefore, giving volume and vasopressor is really worthwhile and having that ready. Volatiles, again, very safe to be used, especially sevoflurane. As far as I know, no cases of hepatic failure or liver dysfunction from sevoflurane. Halothane is known for hepatic failure, but often not used in most countries these days. Desflurane, however, has had case reports of having fulminant hepatic failure, so I would probably just use sevoflurane for that. Now let's talk about muscle relaxants. Now, we all know that muscle relaxants are metabolized in so many different ways. So if you think about atracurium and cisatracurium, it's non-organ dependent. So you know that it's not going to be that delayed, and you might just have to alter the doses because of protein binding, but generally speaking, similar dosages is going to be fine, especially if you're using a neuromuscular monitor. So atracurium and cisatracurium probably universally safe in these patients most of the time. Vecuronium and rocuronium, now these have liver and renal metabolism, so you could expect a prolonged action. And while you can reverse directly with the binding agent Sugammadex, there is a relative contraindication, so again, seek your advice from your superiors about that. Succinylmethonium may also be altered, so because liver failure may decrease your acetylcholinesterase, it might be worthwhile thinking about avoiding it or understanding that it's going to last for longer in these patients. And again, make sure that they're not hyperkalemic. Now, what are you going to do about pain management? So this can be a bit tricky. To start with, as long as they don't have completely, really severe liver failure, most of the time we see patients receiving paracetamol because it does improve pain management with multimodal analgesia. But you would lower the dose. So often in an average patient with some level of liver failure, you might use 1 gram BD or TDS rather than the 1 gram QID that most well patients use. And again, monitoring for the problems of liver dysfunction as well. Non-steroidals often are avoided. They can cause problems with renal function as well. But maybe one dose is not such a problem. But again, it's probably a relative contraindication. Now, opiates can be tricky. Opiates are metabolized by the liver and often some have active metabolites like morphine, which are then excreted by the kidneys. So what you might see people doing is people would give fentanyl as a general rule because it has a rapid onset and a rapid offset, and just do cautious dosing of that, knowing that it's not going to have a much longer lasting effect. If you have a much longer case, you can definitely use remifentanil. Again, be cautious with these very high efficacy medications like remifentanil, but because it is mainly metabolized by tissue and red cell esterases, it doesn't really depend on plasma esterases, which are made by the liver. So in a long case, you could run remifentanil. At the very end, you could then give small doses of fentanyl and titrate those to effect. Again, oxycodone is probably fine. Start low, increase your dosing intervals, and be really cautious and monitor these patients for respiratory depression. Finally, post-operatively, the sicker the patient, the more likely you're going to want these patients monitored in a HDU setting. You want to monitor for decompensation of their liver failure, encephalopathy, ascites, etc., jaundice, as well as renal failure and any extrahepatic stuff like that. And then monitoring their electrolytes, their BSL's electrolytes, again, really worthwhile in this situation. So I hope that was useful for you. That was liver disease in the anesthesia context, and a really fantastic article in the BJA Ed series. So we went through the definitions and we went through the framework of, is this elective emergency surgery and what you do then? If it's elective, you need to go and think, is this an active process? Is this a decompensated chronic liver disease or acute liver failure, in which case postponing is most worthwhile? If there's no active process, no active liver disease, and it's low risk surgery, you can probably proceed safely. But now if it's elective surgery, there's no active problem, it's just a chronic liver failure, it's not low risk, so it's an intermediate or high risk operation, you then go on to assess the patient's risk and try to optimize their inherent risk with a Charles-Pugh or MELD scoring system, as well as looking at the extrahepatic manifestations and try to optimize them preoperatively, and then intraoperatively doing all those things to try and make sure the patient is safe, whether it's increasing your monitoring, watching your medications, as well as treating any problems as they occur, and then post-operatively making sure the patient's safe. So if you have any questions, please write it in the comments below. I hope you enjoyed this video and share with anyone who might be interested. Thanks for watching. See you next time.